Hi everyone, today I'm going to walk you through a HeartFlow AI analysis from a CCTA scan we performed at TrueScan. First, let me explain what CCTA is. So, a CCTA stands for Coronary CT Angiography. It's a specialized CT scan that creates 3D images of your heart's blood vessels. We inject contrast dye and capture images in between heartbeats to see your coronary arteries with incredible clarity. But what makes this extremely revolutionary is HeartFlow AI. So HeartFlow performs two critical analyses, plaque analysis and FFR, otherwise known as fractional flow reserve, to look at blood flow. In this particular case, this patient came in for a proactive heart scan with zero symptoms, and let's see what we found out. So this is the HeartFlow dashboard, as you can see here. On the left, you'll see a 3D reconstruction of this patient's coronary arteries. In the center here, we have detailed cross-section views, and on the left, you can see the associated placement within the coronary artery. And then on the right, we have detailed vessel analysis and showing how much plaque is in each vessel. And on the bottom right, we have a total plaque summary. So that's looking at all of the different types of plaque in all of the arteries, adding them up, and then looking at it from a percentile as well. Now, let's start with what types of plaque we see here. So in the blue, as we look down this vessel, this is the LAD here. This is calcified plaque. So it's hard and stable plaque. It's likely been there for years and is much less likely to rupture. When you get a calcium score test, this is similar to what you'll see on that. The other type of plaque that we can see here is known as soft plaque. It's shown in yellow, and you can see that here in the 3D reconstruction as well, quite a bit of it in all the different arteries. So this is the dangerous type of plaque. It's filled with cholesterol and inflammatory cells. It's highly unstable and can rupture, causing a blood clot to trigger a heart attack. And research shows that this causes major cardiovascular event rates as high as 22% over 3 years, compared to just 5.5% for calcified plaque, or the ones shown in blue. So that's over 4 times as likely to cause an event like a heart attack. Now, the most dangerous type of plaque is known as low-attenuation plaque. It's here in the purple. This particular patient does not have any, but if he did, it's the most dangerous type, which is extremely lipid-rich and very, very prone to rupture. And patients with more than 4% of this type of plaque have a 4.5 times greater risk of heart attack. Many people do not realize it, but plaque actually forms on the outside of the artery. So as you can see, the gray area here as I'm scrolling is the inside, but the plaque actually forms on the outside. And so when plaque breaks through the vessel wall, it causes a heart attack. And around 80% of heart attacks occur because plaque ruptures through the wall and causes a clot to form, occluding the artery. And most of the time, it's soft or low attenuation plaque that does this, hence why we want to identify it and know about it. And CT angiogram is the only type of test in which you can see this type of plaque, and HeartFlow really helps with that analysis. Now, the three arteries that we care most about are going to be the LAD, which is known as the left anterior descending. This is the most important artery, and it supplies 50% of your heart's blood. And blockages here are called the widowmaker because of how important it is. We can toggle to another vessel here. So this is known as the left circumflex. It comes down the left side of the heart and supplies about 20 to 25% of the heart's blood flow. And the right coronary artery, which is here, is the third vessel, and this supplies the bottom of your heart and controls rhythm. About 30% of blood supply to your heart is from the RCA. Now, this particular patient has plaque in all three vessels, so we can go ahead and look into each one. So overall, let's look at plaque burden. So this is adding up all of the different types of plaque within the vessels, and this particular patient has over 1,000 cubic millimeters of total plaque. When compared to patients the same age, this person is in the 94th percentile, meaning that they have more plaque than 94% of people their age, which is a lot of burden. And now we can also look at the composition. 32% of this plaque is calcified, but 68% is soft, unstable plaque. And that's the key finding that is going to be important later down the road as we discuss this. Now, as we go through the vessels, we can actually scroll through them. So starting in the LAD here, we can start in the proximal part, which is the beginning of the vessel. On the right-hand side, we can see the cross section. And in the middle, that's where blood flow goes through. But one of the most important parts that we care about is how much stenosis this patient has. So we can see it here It's less than 30% stenosis, or otherwise known as narrowing. Now, as we come down this vessel towards the medial part, or the middle, we can see that the stenosis actually increases to 30 to 49%. And there's a focal point here of 50 to 69%. Now, the main question here is, how much is this impacting blood flow, and does this particular patient need intervention? And that's where FFR, which is also calculated by HeartFlow, comes into play, and we'll see that here in a little bit. If we go in the left circumflex, we can see that it's mainly a lot of soft plaque. There is quite a bit of stenosis here, also in the medial part. We can see 50 to 69%. This particular patient does not have any chest pain, though, so that's a good sign that it's not really affecting him on a day-to-day basis. And then in the RCA, we can see here in the proximal part in the beginning that he has about 50 to 69% stenosis. So in all of his vessels, he has 50 to 69%. So now the critical question is this impacting blood flow? So normally when you have greater than about 40% stenosis, that's when we really start to see an impact. But stenosis alone doesn't tell the whole story. You can have 60% narrowing and it not affect blood flow, or you can have 50% narrowing in another patient and it significantly restricts it enough for you to need a stent or a bypass. And that's why we use FFR. So with FFR, we can actually toggle it here. We can see with all of the vessels how much flow this patient has in all of the arteries. So you can see here in the LED, you have 0.78. In the left circumflex here, we can see that in one of the branches, we have 0.79 and then 0.75. And then the RCA, we can see it's 0.9 and 0.87. So the RCA is good. Now, you'll notice it's color-coded. The most important thing to realize here is that if you're above 0.8, that means normal flow. So there's no intervention needed. When you're between 0.75 and 0.8, that's borderline. So, we want to commence aggressive medical therapy, possible intervention if the patient is symptomatic. And if you're below 0.75, that's significantly reduced blood flow. So intervention is typically warranted, and it definitely helps improve survival. So this particular patient is borderline, as we can see here. So now putting this all together, we can see that this patient has extensive 3-vessel coronary artery disease, and they have greater plaque burden than 94% of their peers. 68% of their plaque is soft plaque, which is the kind that causes most heart attacks. And so we want to either get rid of that or prevent it from progressing any further through medical management. And we have borderline blood flow restriction, especially in the left circumflex, but the patient doesn't report any symptoms such as chest pain, so we'll just have to keep an eye on that. There is normal flow, relatively speaking, in the RCA, which is good. And as I said, without this test, their first warning of heart disease would have been a major heart attack. And in fact, 50% of heart attacks happen in people with no prior symptoms. And that's why we do this proactive screening, because we want to identify high-risk plaque, we want to see how it's impacting blood flow, and then we want to treat it. Now, in terms of determining treatment, there's actually a great staging chart that we can use. In this particular case, there's 3 main stages. This person, since they have greater than 750 cubic millimeters of plaque, they would be considered severe. So they would qualify for the most intensive type of therapy. So aggressive lipid lowering, we want to see cholesterol below 55. We have things like we can add statins and other PCSK9 inhibitors. And there's a lot of other things that we can add as well, such as aspirin, cardiology consultation for a proper workup, lifestyle modifications such as diet, exercise, and stress management. And obviously repeating the same scan in probably 12 months would make sense, so we can track to see if that plaque is regressing or if it's turning from soft into calcified plaque. So this is aggressive multi-drug therapy because this patient has severe disease. But the good thing is he knows about it. And if this patient had just done a calcium score, they probably would not have known about the extent to which they have all of this soft plaque that they want to get rid of. So using CCTA with HeartFlow, we get the total plaque burden, precise stenosis measurements, FFR analysis, exact treatment staging, and ability to track this plaque and changes over time. So this patient and its physician now has a roadmap. They can pursue aggressive medical therapy, close monitoring, cardiology follow-up, and repeat imaging. And this is why CCTA with HeartFlow is becoming the new standard for cardiac risk assessment. Cardiologists are moving away from calcium scores and stress tests because those tests miss too much. They don't show you soft plaque, they don't measure blood flow as well as heart flow, and they can't guide precise treatment. So to learn more or schedule a scan, you can visit TrueScanMRI.com. And thank you for watching.